so like Sophia said, Manisha beautifully covered a lot of what I'm going to talk about this morning, but hopefully this will be a nice review, and hopefully I can still teach you a couple of different things. For those who don't know me, I'm Alina. I'm one of the second-year EMIMs. So first, let's just briefly talk about the anatomy of the eye. You have your pupil, you have your cornea, which precedes the anterior chamber. You have the lens, and then you have your posterior chamber. The vascular supply of the eye, so you have the arterial supply, which is the ophthalmic artery, which branches off into the central retinal artery, which supplies the inner 3/4 of the retina, and then the posterior ciliary arteries, which are also branches of the ophthalmic artery, which supply the choroid, the optic disc, and the outer, I think, third of the retina. And then you have your venous drainage of the eye, which is the superior ophthalmic vein. So when you're doing ocular ultrasound, you want to use the linear probe. It's high frequency. It lets you see better resolution of the superficial structures. Like Manisha kind of mentioned earlier, you want to use a lot of gel. So in order to keep things less messy, you want to generally put a tegaderm over the patient's eye. And then try to apply the gel on top of that. And then you want to apply basically no pressure, because you don't want to just distort your images and cause pain to the patient. So again, kind of going through side by side with the anatomy and what you see on ultrasound, you see your eyelid, you see the cornea, you see the anterior chamber, the iris, the lens, the vitreous fluid, and the retina, and then behind the retina you see the optic nerve sheath, which is the hypoechoic structure. So this is a normal exam. You just have the patient look left and right so that you can see the movement of the eye and make sure that everything is in the right place. And also that's how you kind of you see that when the eye moves, the diameter of the optic sheath moves, and that's kind of how you figure out what else might be going on. So contraindications for ocular ultrasound are if you suspect a globe rupture. And indications are traumatic vision loss without globe rupture, non-traumatic eye pain, which is mostly endophthalmitis, acute painless vision loss, and increased intracranial pressure. So again, if you suspect globe rupture, stop, do not proceed with the ultrasound, don't do it. However, if you don't recognize globe rupture and you happen to do the ultrasound. So first of all, just kind of going through what globe rupture is, you're going to see a teardrop pupil, you're going to see chemosis, you're going to see subconjunctival hemorrhage. The eye might be very, very distorted. And like I said, if you do go ahead with the ultrasound, one thing is you may cause extrusion of the ocular contents, which is the reason you don't want to do this. But if you do it, you will see this picture, essentially, which compared to normal shows a decreased globe in size, shows anterior chamber collapse. So you see the flattening of the anterior chamber, and you see vitreous hemorrhage. So all of that hyperechoic stuff inside the vitreous, and then you see disruption of the normal globe architecture. Less evident here, but in some cases you can see it literally looks like an oval, or there's pieces completely broken off. So now let's talk about the indications for ocular ultrasound. So one group is traumatic vision loss without globe rupture. So that includes your lens dislocations. So the presentation will usually be blurry vision and a pupillary deformity. It's usually pretty evident on physical exam. When you do the ocular ultrasound, you'll see the lens will be displaced from its normal location. So that hyperechoic oval structure in the middle is the lens, and it actually should be on top. And you can have partial or complete lens dislocation. So if it's complete, the lens will actually be in the posterior chamber and will move completely independently. This one looks like it's a partial because it's kind of staying in the middle. So it's still attached to the anterior chamber. The sensitivity of ocular ultrasound for identifying lens dislocation is about 97%, and specificity is 99%. Another traumatic indication is retinal detachment. So the presentation will usually be a curtain coming down or up. Patients will complain of floaters or flashes. It can progress to full or permanent visual loss and can also occur without trauma. So the ultrasound features will be a hyperechoic line in the posterior chamber. So that's squiggly line that you see. And it'll be tethered in place during the eye movement. So if you see a V shape, that means that it's a complete detachment because it's only attached at the optic nerve head rather than if you only see like one side, then it's an incomplete detachment. The sensitivity of ultrasound for that is 94% and specificity is 93%. Another indication is vitreous hemorrhage. So the presentation is usually floaters, reduced visual acuity, and also can occur secondary to diabetic retinopathy, so not trauma presentation. The ultrasound will usually show like a bunch of stuff in the vitreous, and it'll look like a washing machine when the person moves the eyes. The sensitivity is 85%, and the specificity is around 92%. Another thing you can determine is a foreign body. Patients will usually complain that they feel there's a foreign body. Sometimes you may even be able to see parts of the foreign body, or you get a history that like some piece of, they were welding something or something else happened and a piece of something broke off. You'll be able to see a hyperechoic structure in the posterior chamber, and it'll show a twinkle artifact if you use Doppler. Usually, one caveat is that if the foreign body is located in the posterior fat behind the globe, it may blend in with the fat, so you may not be able to see it as evidently. The sensitivity is usually about 100%, specificity is 99%, so pretty good. Another indication is retrobulbar hemorrhage. Presentation is usually proptosis, vision loss, and elevated pressure. This is an ocular emergency. The ultrasound features of that are hypoechoic fluid behind the globe, and usually the eye itself will take on the globe itself will take on a conical shape, kind of like a guitar pick, so called the guitar pick sign. So now let's talk about non-traumatic eye pain, which mostly you use it for endophthalmitis. So presentation will be severe eye pain, visual impairment, injected conjunctiva ecchymosis. It can happen usually after sometimes it can happen after trauma, but it wouldn't present initially because it takes some time for the bacteria to develop. Sometimes it presents post-surgery. The ultrasound features, you'll see severe levels of vitreous debris and loculated pockets of debris, kind of like we see here. Let's talk about acute painless vision loss. So we already discussed retinal detachment. I just wanted to put it up here to kind of remind you guys that this can be both traumatic and non-traumatic. Another indication for painless vision loss is posterior vitreous detachment. So it presents as a thin hyperechoic membrane that's lifted off the surface of the globe, the posterior surface of the globe, and it's not attached to the optic nerve. And you can see that it's moving freely as the eye moves. The sensitivity for that is about 70%, and the specificity is about 89%. As you may have noticed, retinal detachment and posterior vitreous detachment are pretty similar to each other. So let's talk about the differences between the two. So retinal detachment is an ocular emergency, while posterior vitreous detachment is not. Retinal detachment will present with a constant vision loss, whereas in posterior vitreous detachment, it'll be a fluctuating vision blur. With retinal detachment, you'll see a hyperechoic membrane tethered to the optic nerve, or it can be not tethered to the optic nerve, whereas with posterior vitreous detachment, it's always not tethered. In retinal detachment, you have the membrane is less mobile and adheres more closely to the wall, whereas in posterior vitreous detachment, it's more freely mobile, and in some places it's described as like swaying seaweed. And then the other difference, and it's kind of hard to tell, I guess, if you're looking at the ultrasound without any comparison, but if you look side by side, you can see a clear difference. The retinal detachment, the membrane is a little bit thicker than in posterior vitreous detachment. So here you can see them side by side, so you can see that The retinal detachment is the membrane is a little bit less mobile. It's still attached to the optic nerve, where the posterior vitreous attachment is not, and then the membrane is a little bit thicker with retinal attachment. We also already talked about vitreous hemorrhage, but that, like I said, it can be due to diabetic retinopathy as well, which is why I put it in here. One other thing that can present as painless vision loss is central retinal artery occlusion. So the way that you would look at it is to use a Doppler. So you would go behind the eye, and then so in normal presentation you would see both arterial and venous flow, whereas in central retinal artery occlusion you would only have venous flow and not arterial flow, as you see here. And one last thing I want to talk about is increased intracranial pressure as an indication. So one thing that we talk about is when we evaluate for increased intracranial pressure is the optic nerve sheath diameter. So there's a lot of debates as to what the actual number should be, but the minimum is usually around 5 millimeters. That anything above that is considered increased intracranial pressure. So you're supposed to measure both eyes and an average 4 values for each eye, and then you're supposed to measure the widest point. Usually you do that at around 3 millimeters behind the posterior sheath. So the sensitivity for determining increased intracranial pressure is about 95%. Specificity is a little bit lower, and it gets it varies based on like what the cutoff you use for the determination of increased intracranial pressure. And then going along with that, papilledema. So it will also present with increased intracranial pressure, but you'll also have optic disc edema, which is like that little raised bulge that you see. So if that bulge is more than 0.6 millimeters going into the retina, that's suggestive of papilledema. And then I just have a summary of kind of everything we talked about that you can use as a quick reference. And that's pretty much it. Any questions?
Questions, comments? Yep, Jordan.
You said the bulb is 6 millimeters. That's wide or from?
No, tall.
Tall.
So the tall, like the little bulge that you see going from, thank you. Let's see if I can put it down here. So this here, it should not exceed 6 millimeters in height.
0.6.
0.6, thank you. And then I believe Dr. Kilpatrick wanted to go through a couple of things as well.
I just have one case. So any other questions for her before we talk about it? Very good.
X out of Elena. Just X out of her.
All right, just thought it'd be kind of fun. Look at a case from the last couple of weeks that we had. Just to illustrate this. So this is, I think it's a 15-year-old female in UHB PZR. History of headaches for several years, but now having a little bit of like visual deficit. Nothing else really focal neurological exam, but they had us kind of come down on her eyes, and we definitely saw this. So as far as any abnormality, just getting through after that wonderful lecture, I hope you'll appreciate that there's something atypical in this posterior chamber. That we see a bulge there, and really any sort of bulge, we have to answer why is there a hint of papilledema.
Yeah, click right.
You press here, now we're seeing the optic nerve right in the middle, and as far as the sheath, I mean, hypofocus on the outside.
Yeah.
And measuring it out, you have 0.3 back, going across into the other, 0.62. Okay, it seems to be positive. Then we have the papilledema on the other side as well. The other eye is there. Seeing the balls going in. So with this case, I wouldn't have that finding. It definitely prompted them to take this type of headache seriously as something else, atypical from the patient's history of chronic headaches. We talk about trying to get a gold standard, like for looking at something like intracranial hypertension. These things can be helpful when other more common things fail. So they had the sedates, they couldn't get the LP, they couldn't get an opening pressure. So there are lots of obstacles that kind of like step in the way of more common ways of making the diagnosis. But based off this, they're all speak to Peds Neuro and get them admitted, and they believe the image is enough to start like a treatment for intracranial hypertension. So one thing that I think is kind of fun for us is like attendings, having all the residents around. You guys keep us really honest about things, and there's a lot that we're training with that we kind of stick to these old dogmas, and we don't really challenge them at all until one of you guys comes up and says, "Oh, wait a minute, why are you saying that? What's the evidence for that? Does that make sense?" Certainly, when I went back to just when I was a Sano fellow, I remember hearing about optic nerve sheath diameter and being told it's useless. And just meh, don't even bother. You can't incorporate this clinically. It's not ready for prime time. And so it's fun when like Alina and other people come up to me and say, "Well, wait a minute, like I was reading more about that. Like, is there a way it could be used?" And so they have to actually go back to some of the evidence and think, "Well, wait a minute, maybe there is a way. Maybe that's a pretty good sensitivity, and maybe I should like reevaluate like how I can incorporate that in my practice." Obviously, you use different things in different capacities. Something highly sensitive, maybe it's not going to be that specific. It's not going to be, but if we're just using it for a screening exam, like if I just have a patient coming in and no other sign is pointing me towards going further, admitting the patient, getting an MRI, doing an LP, all these invasive procedures, can I use this as an effective screening study to say, well, all right, it's good enough with that 5 millimeter diameter that if that's not positive, I don't have to go down that pathway. I don't have to, especially in a resource-deprived environment, take up that MRI. People who are self-pay, give this person a $3,000 a night bill to stay in the hospital so they can see Peds Neuro tomorrow. Making those type of decisions. And evaluating a sensitivity that high, yeah, I probably should think of how I might be able to change my practice, like in regard to that. And just for comparison, I had to remind myself that one of the other sensitivities that's much lower is, of course, the SARS-CoV PCR, and that's nowhere near 95, and that's something I think has affected all of our practice quite profoundly in the past year. So just something I'll have to think about and keep using literature. Right.
Awesome.
So what's like when you compare with ophthalmoscope?
So on physical exam, it's notoriously terrible. Like the papers that come out for that, people can't see it, people can't appreciate like a papilledema with ophthalmoscope, especially different specialties. Like I think that because I'm biased, the studies I look at are always the ER ones. And it's how many times could they actually accurately appreciate papilledema? I can't remember, it's like 40% or something very small. So I think because that's so small, it's not necessarily a skill that we teach and practice that much, which then just kind of cascades into even more inaccuracy at being able to appreciate that.
The disc bulging, like how sensitive or specific is that, or is that commonly seen in conjunction, or is that just like a later finding, or like?
That I don't know. I mean, so going back to what Shtridler is, a very normal variance is the width. And part of the reason they selected the 5 millimeters is they wanted this to be highly sensitive, not specific. And that's why when you look at like just normal med student teaching in Sano, 30 fully healthy normal people in front of you, you know, maybe half of those are actually going to be greater than that 5 millimeters, just that's their anatomy. In which case, not specific, not helpful in picking up who actually has like some like lesion there, but by shortening it to 5 millimeters, maybe if they're sensitive, can use the screen out. A patient who is on doxycycline and now has tunnel vision, can we effectively use this as a way of saying, well, this is not the doxy-induced intracranial hypertension. Like I don't have to go down, the route of LPing this kid. That could be some value to that. Papilledema, I was thought it was a little bit more advanced, so a little bit less likely to be an anatomical variant, because now you actually have bulging into the posterior chamber. I couldn't find specific studies that support that. It makes sense to me. Like if people just might have natural widening, but no one should really have natural bulging. And
Yeah.
so,
It'd be interesting to see that in conjunction with the length or the diameter, what the sensitivity increases to.
I think in general, for everyone right now, I'd say if you see papilledema, really push yourself to find an answer for it. Whereas just a widening really can be through your clinical context and how you're using the sonic for that case.
Yep. Awesome.
Question. For that 95% sensitivity, was that using the 4 measurements? So that was that like 2 in each eye?
So this is definitely a wonderful question, and I would kind of redirect ultimately towards those who are gifted at EBM and literature analysis, because this is really touching on the difficulties of looking at systematic reviews. But also now we're taking into account the variances of, well, how many studies have this threshold of 5 millimeters? Okay, the ones that selected out. Within that, how many of those studies use 4 measurements? Some use 3 measurements. They look at one eye with an ER person who did it with someone else. And I think you really touched on like all the different variances that can kind of play into looking at systematic reviews.
Any other questions?
Thanks.
Awesome. Thank you.
So,